From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good evening, folks. This is Dr. Paul. Thank you very much. Today I want to talk about Toxoplasmosis. Toxoplasmosis basically is caused by Toxoplasma gondii. Toxoplasma gondii is an obligate intracellular protozoan. So it basically lives intracellularly and causes devastating problems. It may be acquired in utero or following a systemic infection. So you can have a congenital infection or a systemic infection. And many times the domestic cat and other feline species, they serve as definitive hosts for the parasite. So the cats, they are the main hosts, and susceptible women who acquire this infection during pregnancy may transmit that infection to the fetus, and it can be fatal to the fetus. And susceptible women, when they get during the pregnancy, folks, that's a very, very serious problem that need to be treated immediately. Otherwise, the fetus can have serious problems even beyond the delivery. The fetus as the live-born baby, can have problems. So remember that important point. And many times there are two forms, bradyzoids and tachyzoids. Remember those two forms. These two forms, they can transmit across the placenta. So bradyzoids and tachyzoids, and they can cause the problem, both in immunocompetent hosts and immunocompromised hosts. Immunocompromised, that's most importantly HIV, and diseases like lymphoma and leukemia, or people who receive transplantation, they are at high risk for developing aggressive disease of toxoplasmosis. And most commonly, toxoplasmosis in these immunocompromised patients attacks their brain, and also chorioretinitis, heart causing myocarditis and lungs causing pneumonia. So the acute infection or reactivation has serious problems. And also in brain, Toxoplasma encephalitis is one of the most common cause of mass lesions in the brain in persons with HIV or AIDS. Now I want to talk about the ocular toxoplasmosis, the toxoplasmosis that impacts the eye and causing chorioretinitis. And in the United States, it's very, very common form of congenital infection. But folks, it can happen even during the acquired form. And the majority of cases of ocular toxoplasmosis are acquired form. But as I said, congenital infection can happen, and the interesting thing is congenital infection is asymptomatic until second and third decade, because that is when these toxoplasma cysts, they rupture and they release those bradyzoids and tachyzoids into the tissue. You see? So bradyzoids and tachyzoids, they remain dormant until second or third decade, and then they release into the retina and cause chorioretinitis. So that is an interesting thing, and at least that sounded interesting to me. Now, typically, acute infection will present as unilateral eye disease. So if you get acquired, it most commonly unilateral. If it is congenitally acquired infection, it is bilateral. You see, that's another interesting point, and also easy to remember. So it's a clue. If it is a bilateral toxoplasma affecting the eye, most probably it is a congenitally acquired toxoplasmosis. If it is affecting just one eye, most probably it is an acquired toxoplasma infection. Now let me talk a few minutes about symptoms and signs. Patients with toxoplasmic choroiditis or chorioretinitis, however you call it, they present with flutters and blurred vision. So those are the important symptoms: flutters and blurred vision, and many times they can have even photophobia and pain in the ear. And in the eye, you see floody white areas of focal necrotic retinochoroiditis, basically inflammation of chorion and the retina. And you see that floody white areas. And those are the lesions, folks, caused by toxoplasma. And many times active infection happens in one spot, while the scarringness, the scarred tissue, will be seen on the other side. And the cystic lesions can also cause edema, and that can cause glaucoma, you see. So all the cycles can happen. Sometimes iridocyclitis with a severe infection, so affecting the iris. And the elevated pressure, as I said, can cause glaucoma. Now, laboratory diagnosis, basically a positive serologic test for Toxoplasma gondii in presence of clinical signs and symptoms is diagnostic of toxoplasmosis. So you go by serologic tests first. They are the primary means of diagnosis. But you should carefully interpret the results. Just a serologic test positive doesn't mean they have an active infection, but you can always use PCR of body or blood, because PCR, polymerase chain reaction, shows the stachyzoids and the bradyzoids in tissue preparations. And you see the cysts even in the placenta or fetal tissue. That direct visualization helps when the diagnosis by serologic test is in doubt. Now, you know and I know, they teach us in immunology class that IgG and IgM, these are the two things. And IgM antibodies, they are measured by ELISA. You can use ELISA test or particle agglutination test. And they appear and they decline faster than IgG antibodies. IgG antibodies and IgM antibodies, we look for the both. And if you don't see IgG or IgM, that means there is no infection at all. The patient doesn't have active or inactive infection. Acute toxoplasmosis in the immunocompetent host is best documented by analyzing these two things, IgG and IgM, in paired blood samples. And you take them like 3 weeks apart. Why? Because IgM or IgG, they can only persist for several months even after acute infection. So if you see a high titer after one time high titer, doesn't mean anything. So you need to follow like every 3 weeks. If you follow that, and if there is a 4-fold rise in the titer, that's definitely an indication of active infection. So you see, folks, you do these tests with a sense of clinical symptoms and signs. So PCR, and also seeing tachyzoids in histologic examination is one of the most commonly used diagnostic methods. And as I said, clinical symptoms, if you see those flutters with blurry vision and pain and photophobia, then a serologic test is all that you need. So go by clinical symptoms and then demonstrating these antibodies, IgG and IgM. That is the most commonly used attacks. And if you are still having doubt, go for PCR. PCR, it's an expensive test, so you need to use it carefully, because you don't want to throw money on all these unnecessary tests. And now let us talk a few minutes about what happens in the babies. Same thing, IgG, IgM. We can also add IgA, IgE in the newborns. And you take blood and CSF, an amniotic fluid. You take those specimens and you need to assay them by PCR. And that if you see that means congenital infection has happened. So you should not leave it like that, folks. I mean, you need to do a thorough ophthalmologic exam, a thorough auditory, and a thorough neurologic, and also a lumbar puncture and a CT scan, because toxoplasmosis can affect the brain and cause CNS calcifications. So you need to do a CT scan of the brain to see CNS calcification. So an ophthalmologic, auditory, neurologic, CT of the brain, those are the important things you need to see, to do when you are dealing with an infant that is suspected of being infected by this problem. Now let's go to the treatment. There are two things: trisulfapyrimidine, pyrimethamine. These are the two medications you need to absolutely remember. Pyrimethamine, okay, and trisulfapyrimidine. These two medications are absolutely important. And also, you need to give leucovorin calcium weekly. Hi there.
Hey, Dr. Paul, would you like to hear about your next patient?
I will take care of it.
He's in room 2.
Okay. So you need to give leucovorin. Why? Because pyrimethamine can cause neutropenia. So you need to do CBC to make sure that patient is not developing agranulocytosis and leukopenia. That's why you give leucovorin and do CBC. The other medication is clindamycin with the trisulfapyrimidine. That regimen can also works. And clindamycin and the clindamycin, one of the most important thing is it can cause pseudomembranous colitis. So you need to be careful with the clindamycin also. The other medications you can use are sparamycin and minocycline. And sometimes subretinal neovascularization happens. In those cases, you need to use photocoagulation or vertiporfin therapy. Okay, so argon laser photocoagulation or photodynamic therapy with vertiporfin. These are the things you use when neovascularization happens. And the other complications, anterior uveitis. What happens when the patient has anterior uveitis? You need to use corticosteroids and cycloplegics. Now, a few things about corticosteroids. You do not use periretinal injections. You can use systemic corticosteroids in conjunction with only antimicrobials. I mean, when there is a severe inflammatory reaction due to toxoplasmosis in the eye, you can use systemic corticosteroids, but only with antimicrobials. You should never use systemic corticosteroids without antimicrobials for the prolonged time, because they have their own side effects, sometimes very serious side effects. So folks, Toxoplasma gondii is very important because it can cause chorioretinitis. Please remember that. Whether it is reactivation or an acquired infection, congenital infection, it can cause all kinds of serious eye problems, starting from optic chorioretinitis to uveitis to optic atrophy. And as I said, it is caused by Toxoplasma gondii, an intracellular, obligate intracellular protozoan. You use pyrimethamine, trisulfapyrimidine, and clindamycin, sparamycin, minocycline, corticosteroids, cycloplegics. All of them play a role in these patients' treatment, and you tailor the treatment according to the disease, according to the presentation, according to the patient. If a patient is pregnant, you start with the sparamycin. Okay, and beyond infancy, the treatment is the same. You start with pyrimethamine and trisulfapyrimidine, and you use corticosteroids as needed. And pyrimethamine has those side effects like upsetting stomach and also causing agranulocytosis and leukopenia. That's why you need to use leucovorin, and also monitor their CBC, their complete blood counts on weekly basis. So those are the most important points, folks. If you need anything, please post. If you have any other important points, post that on our website. Thank you very much. Have a nice day.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.